This is a case of extended right hemicolectomy with cranial-first approach. The patient is a 66-year-old male with history of hypertension and diabetes mellitus, diagnosed with T3N2 adenocarcinoma in the cecum, near obstruction status. In this case, we apply the cranial-first approach for extended right hemicolectomy. So surgical step is follows: supracolic dissection, inferior lateral dissection, medial dissection, followed by extracorporeal anastomosis. First, we begin the dissection through a cranial approach, incise the gastrocolic ligament. Dissect the fused fascia and mesocolon to reach the plane of the hepatic flexure of the colon fully exposed and dissect near the middle colic vessels. You can see that the duodenum, pancreas, and SMV are well exposed. Placing gauze over the T-colon separates the mesocolic envelope from the duodenum, pancreas, and stomach omentum, making medial dissection safe. Now, we turn to inferior approach. We dissect the posterior space of the right colon between the visceral and partial peritoneum, called Tolt's fascia, from the cecum to hepatic flexure. The plane between the ascending colon and the visceral duodenal pancreatic peritoneum or Fret's fascia is continued to uncover the head of the pancreas' second portion of the duodenum. You can use the gauze to maintain a safe dissection plane. Finally, we turn to the medial approach along the left side of the superior mesenteric vein. To ensure a sufficient margin of mesentery, radical node dissection is performed starting from the distal SMV without dissection along the iliacolic vein. We identify iliacolic artery and vein. Clipping and cutting was done. As lymph node metastasis was suspected in this patient, extensive lymph node dissection was performed along the course of the SMV and the branch of iliac artery was ligated. The gauze that was placed above the T-colon is visible in here. During dissection along the SMV from the iliacolic vein to right colic vein, we can see the surgical trunk of the gillet. The right colic vein is identified, clipped and cut. The right colic artery running next to the right colic vein is also ligated. After that, we are dissecting further upwards from the right colic artery to find the middle colic artery and vein. Clipping and cutting was done. There have been anomalies in the presence of IMV in the SMV, so caution is necessary during dissection. Now, the ligation of the major vessels is complete. After the medial dissection, you can see the ligated vessels. The patient underwent iliacolic anastomosis through mini laparotomy and the operation was finished. Final pathology was T4 and 2BM0 and there were lymphatic, venous, perineural invasions. The patient recovered without complications and was discharged.